All right. Well, my goal here today was really to keep this pretty on point and um, not necessarily short, but value everybody's time. And I appreciate everybody for taking the time to join, and of course registering, but also taking a look at the ebook that was put together called Beyond Sobriety. Our objective here is pretty simple. I want to sort of bring us up a few levels and talk about this idea of recovery capital, define it. For some of you, it might be maybe a newer term. If it's not, and you've been around the idea for a while, great. We're going to sort of expand what's possible of the way we think about recovery capital. Look at it from a couple of different levels, from the individual all the way up to the community, and why that's important if you are a provider of addiction care or behavioral health care or recovery supports, to be thinking of recovery capital not just as something that is inherent in an individual, but exists ever present within our communities, and how that can create new strategies for you as a provider in a community to actually address a pretty big problem in the world, and that is the addiction crisis. I see a few other folks joining in. We're just getting started, so don't worry, you haven't missed much at this point. So we'll talk about what recovery capital is. We're going to talk about the subjective experience and why it's really important in what that means is actually asking individuals questions in a discrete and defined way. And that information has great value to it. We'll talk about why there's some pitfalls to that, but also the strength of it. What this looks like in terms of a strategic priority at kind of a higher level, and then actually show you some data. So when we're actually measuring recovery capital, what does that look like in real life? So this is me. I won't spend too much time on me except to say that I've been working in or with Recovery Capital now for about 8 years. I got started in that as the Chief Innovation Officer for a recovery community organization, or what we called an addiction management organization in Sioux Falls, South Dakota, called Face It Together. Recently, I've left that organization. In about 6 months, have dedicated my work now to designing consumer or customer experiences in behavioral health care, helping organizations better manage outcomes and define outcomes, but also measure outcomes in terms of recovery capital through a very specific tool. My connection to recovery capital actually started before I knew what the term was. That's me in 2005. This is 1 month after being sentenced for what was a third offense felony DUI. It was my fifth DUI lifetime. And during the course of the sentencing, which was a month earlier, the judge was describing all of the things that I had had in my life, like college education. I worked in radio as a radio broadcaster, rather successful for almost a decade. I had access to financial capital. I had family members who loved me. I lived in good communities. Why is it, or how was it, that I ended up with all of that, plus attempting suicide a number of times and everything that went along with addiction over the course of a decade? How did I get into her courtroom? She didn't know the term recovery capital. She didn't know that that's what she was describing. All she knew was those were the things that we were supposed to have that was supposed to keep us away from addiction. After that sentencing, and as I set a path forward to go into a sober home in Sioux Falls, South Dakota, and then thinking about where my life was going to go, going back to college, getting a degree in history, taking a course with a constitutional law professor who was a former public defender, and her saying to me, David, if you think you're going to go back into journalism or radio, you're mistaken. You will waste your life. You need to become a lawyer. As a convicted felon, that didn't make a whole lot of sense. But she wanted to see that happen. So she helped over the course of time. And eventually I got into law school, graduated law school, took the bar exam, passed the bar exam, and then had to go before the court, go before the state Supreme Court in South Dakota and the Board of Bar Examiners and explain how 8 years of recovery and sobriety could allow me to be of the good moral character to become a lawyer. And a lot of different things were happening at that time. But ultimately, as my life grew and changed, and I got a college education, and I got employed, and I got married, and I rekindled relationships, and all those other things, found what my values were, my beliefs were, I was reconnected to the term recovery capital. But what happened in the middle of that was the ability to go back to that courtroom and with that same judge, instead of wearing an orange jumpsuit, actually put on the lawyer suit and get sworn in as a lawyer in the state of South Dakota. It was in that last process there in engaging with the judge and engaging in a question from the organization that I was working for, how do you measure addiction recovery? That recovery capital became a big part of the work that I now do. And what I've come to learn over the years is that we talk about these terms, we talk about recovery capital, we use some of these assessments, we kind of sort of talk about outcomes, but we don't have a systemic approach to what are those outcomes? What is the actual glue between all of these pieces that's actually going to address the crisis that's before us? 2020 is not an anomaly in terms of overdoses and overdose deaths. It's just a trend that continues. Why? Well, in part because of the underlying fabrics that connect us, social, economic, environmental determinants. At a broader scale within our programs, as I'll talk more about as we go on, sobriety really is the driving factor in a lot of this. That is still our key indicator. And as that remains a key indicator in our approach, we end up with strategies that focus just on the substance, whether it be at the individual level in a program or at a national level with all of the various funding that comes down through the systems. So with recovery capital, we can kind of shift that narrative. We can look at the social determinants around us, use that as a framework, and begin to start to think about how we as providers or as policymakers or researchers or wherever we're at, or even individuals, how that connects and transforms at a much broader scale. So we're moving upstream versus sitting at the bottom of the waterfall. So let's just define a few things. We'll put everybody on the same page. Recovery capital is really kind of a simple concept. It's the depth and breadth of internal and external resources that individuals, all of us, can tap into or has access to or happen to just exist in our communities around us that can either begin the process of recovery or sustain our well-being beyond that condition. Granfield and Cloud, they first defined this in 1999. I'll talk a little bit more about sort of their work and how recovery capital came from a place of social capital. But as we look at those parts, those independent pieces, if you will, that really aren't independent, they're all interconnected. These component parts, when we look at recovery capital, they can be broken down into pieces, measured, tracked. We can define outcomes and indicators off of that structure and start to design strategies both internally within our organizations or so that we can improve our care that we provide, but also even broader. So as we become present in a community, how do we change our relationship to the community? I don't need to tell anybody who's joined here today that behavioral health, mental health, and addiction care has sit and still sits in a silo in communities, typically isn't at the table for big, broader strategies. You're never going to see today somebody who runs an addiction treatment facility go to a city council meeting and the topic is complete streets. You're not going to see that. Why you wouldn't see that, but you should. And I'll sort of get to why that might be important. But these are the domains. And so when we start to think about the framework of recovery capital, we want to break it down into these domains: social capital, personal capital, cultural capital. Kind of define these a little bit more as we go, but as you can see, what we're talking about is all the bits and parts of those particular areas. Just to back up for a moment, William Cloud and Robert Granfield, they sort of fell into recovery capital through thinking about social capital. And it wasn't even social capital that they were thinking about. What they were thinking about was this idea of natural recovery. Most people who overcome drug and alcohol addiction do so without the help of some intervention. They don't go to treatment. They typically don't go to AA. They wake up one day and choose a path that relies on the resources in the community around them. And that social connection, as they found by interviewing people, was one of the big key factors. But they realized there was a lot more to it. And so it was more than social capital. It was more than just this natural recovery process. There had to be other things. And that's where we get to these other domains. But how do we learn about those things? How do we learn about somebody's family connections or somebody's general well-being or their values or what they're missing in terms of transportation or safety in their community? Well, we have to ask. We have to use well-designed, easy to understand, either statements or questions, and we have to ask the individual. It's one thing to ask somebody whether or not they're employed, and we might be able to gather that information in a lot of different sources. But sometimes it comes down to the effect of that employment. Is it good for their well-being that they go to work every day in a really hard, difficult job? But not so much that the job is difficult, but maybe the culture is difficult. Well, if we never ask about the culture and we just check a box that somebody's employed, we're missing much more of the experience around that one element, just employment. So we have to ask these questions. And we can really get from a person's life when we start to ask these questions. We do a couple of things. One, we're growing a map of that person's life. But as we do that at scale for 10 people, 1,000 people, 1,000,000 people, now we start to get this voice and this picture of people either in recovery or actively struggling. We get to see these communities that they live in from their own observation. That's incredibly important, has immense power, one of which is that we can start to change the recovery narrative. We could start to look at stigma in a different way in how people are living in the community and how people are saying the community is impacting them. For organizations, this really creates a bit of a differentiation. If you are measuring all of these elements, all of these components of recovery capital, and you've got the ability to analyze it, you're going to do two things. Internally, your people are going to have a better education and literacy just around data alone. We're not going to move away from more or less data in our world. There's always been data. How we use it and the way that we use it and whom we use it with is really what's critical and key. But people need to have a vocabulary, a dictionary, a methodology for really understanding that. That's data literacy. And the more we increase that, the better individuals can then use data to sort of drive change and outcomes. But what that also does is it creates a new culture internally and externally around how we engage and how we start to do process improvement versus outcomes definition and just pointing at sort of an outcome and saying that's what we want. Where change really happens is in the process. I see we got somebody joining. Thank you, JD, for joining us. So now when we start to break this apart even further and we start to think about a strategy around recovery capital starts with the individual giving an observation of their world. That's really great because it now presents the opportunity of doing very personalized care for that individual. We can track change. We can identify outcomes at that individual level. And that's really critical and important. But from that point, as an organization, we can then take the population of that information and start to look at both how are the people in certain groupings, or demographics, or program types, how are they doing relative to the interventions that we're providing? And of course, knowing that we might provide an intervention, but there is an external force that's greater than the intervention that we're providing, that's important to know. But we could also start to look at it and say, well, we've got 5 recovery coaches, we've got 10 therapists or social workers, and here's what they do. But we're finding out that the greatest effect that people might having, and this is going to show my bias, are the recovery coaches. They're driving greater recovery capital versus the social work team or the therapists. Now the organization can start to ask a lot of different questions about who needs to be active and when. But then at a community level, that just goes to a completely different place, because now we start to see where there are strengths within the community or deficits, and we can start to change the game. I want to spend a little bit more time on each of these as we go through for a moment, and just go back to the individual. If we're spending a lot of time focused on whether or not somebody is sober or not, or hasn't used or is using alcohol or drugs, we miss a lot. We miss a lot of the why. Sometimes we don't want to talk about the why. Why is somebody actively using drugs? Because that either places judgment, or we start getting into uncomfortable positions of choices that people make. And I know we want to sort of get to this place of sort of a pathology around a brain disease and that kind of stuff, and that it's not about choice. It's because there's a brain challenge. That's one thing. But external of that, there are a whole lot of other factors. We all know that. So what are those factors, and can we actually measure them? And that is the sort of give and take that we're doing when we start to measure recovery capital. Is now we're changing the conversation. We can take somebody's use or non-use or constantly thinking of use, and we can kind of push it aside, and we can look at the other things that are the cause for why somebody might decide that, I get off of work at night, the first thing I'm going to do is have a beer because that calms me down. But that turns into 2, that turns into 20, and now we have to roll that back. We can start to do that if we're measuring the right things. That becomes a full circle when we get to the point of, that starts to think about how we can build up resiliency for people using cognitive behavioral techniques or other ways of thinking about what's happening, what's the behavior, what's the thought, what's the action, what are we doing, what's the emotion in those elements. We can start to change that narrative just a little bit. Organizationally, as I mentioned just a bit ago, recovery capital measures, if they're well framed and they are well defined within your programming, can really change what you do. And one of the examples I want to mention is, say your organization, does a lot of employment support. You have a grant to help people write resumes and connect them to job banks. That's really important. It's really great. And you might have a 70% success rate of getting people into a job. But that's where typically those programs end. And we can go one step further beyond that if we're constantly measuring that person's recovery capital, because now we can see, we got them into a job, but is that job actually helping them? Sometimes we got to make hard choices and we just have to take a job. But we can reframe those things and track those more in a more detail way over time. And I want to spend just a couple more moments talking about the community level. One of the challenges is in our communities, as I mentioned earlier, behavioral health, addiction care has lived externally or in a silo. It's typically pointed at as part of the problem and not part of the solution. If you've got hundreds or thousands of folks coming through your program in a given year, living in your community, returning to your community, and you have helped that group of individuals become more engaged, more civically minded, contributors to society, you now have a completely different value position in the community for solving some of the problems that continue to plague us. You can not just stand up and say, well, we get these people. Well, look, here's John. You can bring data. You can bring data to the table, and not just graduation rates. No, you can look much deeper than that and say, not only did these people come through our program, but when they leave our program and they engage back in this community, here's where they're doing well, but here's where they're not. These are the things we should be concentrating on. And now you can help move policy, move resources and allocation of funds to really solve some of the big systemic problems that exist that perpetuate addiction long term. It's a completely different position that providers have just not been in. And now there's an opportunity to really do that. William White, who has been writing on Recovery Capital for probably 15 years now, well, yeah, about 15 years now, picking up from the work of Cloud and Granfield and others, has written this, that Recovery Capital, because it's so broad, because it's looking at more than just the drug or the alcohol or the substance, that can be the potential antidote for a lot of the reasons why our recovery efforts over the years have failed. There's been a lot of effort from advocacy groups and big, huge potential for change at a national level or even a global level, and they really haven't moved the dial. And so this is pretty prescient from William White in 2008. I think it's time now to take these words and put it into action. So now I just want to talk a little bit about the data. Well, what does it look like when we start to see some of this data come together? And where I want to start is with me personally. I've been measuring my recovery capital for a long time. I haven't had a drop of alcohol or what we would call a narcotic drug or since 2005. But I fill my body with sugar. I eat food for emotional reasons. I do a lot of other bad things, and but when I look at my recovery capital over the years, I do get people say to me, well, why do you haven't had a drink for 15 years. You don't need to measure your recovery capital. It's pretty strong, right? It's not what it's about. Life has changed. And as you can see from this, from December of 2019 through December of 2020, my recovery capital has been all over the place. A massive dip in April because I knew a job change was coming. I was in the middle of a move. A lot of my social networks and other things were changing. But I measure it every 30 days. I'm mindful of this as it's going on. It might go down, but that's okay. Some days I walk 8,000 steps. Some days I walk 26,000 steps. My recovery capital is the same in that respect. It's what you do with it then as you're measuring it. It becomes much more of a mindful practice from day to day. Again, that's just like an individual level. How would you bring this in to practice at an individual level? But you can also see this at a population level. We start looking at recovery capital against demographics, for instance. So in Palm Beach County, for instance, where they've been measuring recovery capital for a little while, we're looking at demographics over the course of the last year. And what's really fascinating when you look at this of individuals who come into various programs, whether they're full-time or they're unemployed and not looking, we start to see some interesting diversions of recovery capital. In particular, around part-time folks, people who have a part-time job, and then people who are retired versus people who are temporarily unemployed, and then people who are full-time employed. This comes over the course of 2020. So there might be some nuance here that's COVID related, but here we have people that are part-time employed. Their personal capital is low, their cultural capital is higher, but their overall recovery capital is higher in the aggregate than folks that are full-time employed. Why might that be? One way we could think about that is the folks that are part-time, they're living in uncertainty and they've gotten comfortable with that uncertainty in an uncertain time. People with a full-time job, when times are uncertain, they may not know whether or not that full-time job is going to be there. That's just a supposition. But then when we look at folks that are retired, the game is completely changed there for them. That might be a whole lot of life transformation stuff that we're curious about. But then again, there's this group of temporary unemployed. Uncertainty is maybe the thing here that's navigating some of this differentiation, but they've got high cultural capital and very low social capital. Being temporarily unemployed has probably put them into an isolation state, and things have changed on that front. Again, those are questions that can now be asked because we have this data. And if I'm a program and I'm looking at these things, I want to think about engaging these people who are temporarily unemployed different than the folks that are full-time employed. If I'm coming at them with the same hammer, thinking that they're the same nail, we'll never move the needle. One last bit of data. This is data that comes out of Palm Beach County over the course of 2020. And the reason why I want to show you this particular question and the results of this question is because you've probably picked up the newspaper. I'm showing my age. You've probably turned on the internet and wherever you get your news, and you've read a story in the last month or two about loneliness or isolation. It's a hot topic. It's big in the zeitgeist. Why? COVID aside, we have had over the last decade a big challenge around isolation and loneliness. In the world of happiness research or subjective well-being research, this question is asked as a driving indicator or a leading indicator of whether or not groups or individuals will be struggling in their well-being or happiness. What this question gets at is, can I count on my friends or a social network when things go wrong? So if something is happening to me, can I pick up the phone, or will they know that it's happening to me and will they pick up the phone or come to me? If we're isolated and we find ourselves being lonely, that creates all kinds of issues or challenges. In Palm Beach County in 2020, between those that answered strongly disagree, and uncertain, that response rate of suggesting that they don't have that person is 83%. That should cause enormous concern. And I know for the folks that are working with this information now in that location, there are people who are very concerned about what this means in that particular community and want to do something about it. Previously, this wouldn't have been on their radar. It wouldn't have been something that they concerned themselves with. They would have continued to be thinking about, well, we need more money to improve job retention or employment or housing, which is all important. But this is the people in that community speaking back saying, I don't have somebody to go to. Now, it's not their fault. There's a whole lot of things going on, but this changes the conversation. And this brings everybody in the community into it. And no longer are we thinking that this might just be about addiction. This could be something that's going on globally within that particular community. So that is kind of when we think about all of the various elements of recovery capital and we're looking at it, we're now starting to have a different conversation. We're not spending our time just thinking about a person's use or a person's severity index. We're actually looking at where do people live, what is life like, what are all the underlying factors that lead or contribute to a reason why somebody might want to use drugs or alcohol as a coping mechanism. That creates dependence. Dependence leads to addiction. We know how that works. We can reverse that cycle and take it backwards and say, well, if all of these other protective factors, and there's a lot of psychological safety in our community through these domains and these components of recovery capital, we can now start to build that stuff up outside of the programming that we're working in, the interventions that we do. And now, with that resiliency built in, people that come into this community, if they might be susceptible, there'll be greater protection in the community, embedded in the community, so that they don't lead into a life of addiction. Now, as a program provider, that could scare you a bit, because now the people coming into your program might be less. But I will venture to say, over the long term, that's what we want. That's the outcome we should be shooting for. Like in Iceland in the last 4 years, they, again, this is an island with about 300,000 people, but they used to have about 100 addiction treatment programs a decade ago. They've got 2 across the entire island. And it's because they started to focus on the protective elements in a community recovery capital, as opposed to interventions focused on the drug or the alcohol. So I'm going to just wrap up here in 2 minutes and just very quickly share sort of how did that data all come together, and what's my focus into it. And it's through this particular tool, the Recovery Capital Index. And so part of what this means is when we have the right systems and tools in place, we can look at this information in real time, we can apply it to our care, we can manage it across people and systems, and we now have the power to bring a lot of these concepts that I've been talking about into action. And the Recovery Capital Index is a particular tool that I invented and have developed over the years, and is continuing to develop to bring it out to people. One of the things that we've learned over the years is that when you're engaged in a lot going on, a lot of change in your life, a lot of these digital tools can be disruptive. We still, despite what some people might say, email's not going away. Text messaging certainly isn't. But we can put a link in those communications channels and get people to complete the survey and have this dialogue through that instrument. The Recovery Capital Index is a 68 question survey. It scores from 1 to 100. It's been validated. We've taken it through the ringer with biostatisticians to validate the reliability of the instrument. It measures what we say it measures. And what I mean by that is, if somebody comes into a program and they say that they are currently struggling, and then 45 days later, that subjective marker of their recovery changes to in recovery, their recovery capital in mass, in aggregate, will go up. And so we've validated that a number of times. So that's recovery capital at a very high level of thinking, how could you bring a standard measure into your practice that's looking across multiple domains and components, so that you can start to now move beyond just a major indicator for a lot of programs, which is sobriety, and think about what are the other factors that might be things that we don't necessarily control, but at scale, because we're part of a community, we can start to influence because we're measuring the right things. And we now become much more valuable as providers in our community to bring solutions to the community as a whole. So we've got about 7-8 minutes left, and I will stop sharing my screen. And if you have any questions or comments or thoughts, I'd love to entertain them. And since we are just using a standard WebEx, all of you feel free to unmic yourself and ask away. Thank you for the patience and listening.
David, I'll jump in. Sorry to jump to the front of the line, but I was interested in the data that you said you had in Palm Beach and that large group of providers that you had, because to me, the hardest part of this is picturing what this looks like as it enters the current systems and sort of improves them. And so how does that work, if whatever you can share about what they're doing in Palm Beach, and what does it look like when the providers use the recovery service, the Recovery Capital Index in their systems?
Yeah, in that particular instance, so the funding source and the organizing factor is the county. So it's a government entity, and they have got care coordination agreements, care management agreements across about 30 or 40 different providers within that community, all of whom they operate through a managing entity and various factors. And so, because that structure already exists, we're able to put the tool in the middle and a shared platform so that individuals can go into any one of those programs and that data is instantly available to all of those programs. So, Shannon, if you went into a detox and we gave you a recovery capital measure leaving the detox and then referred you off to inpatient residential source, who's also part of the network, they now know where you've started. They've already got your baseline. We don't have to do it again. And we can keep that continuum going as you're moved through the system, and it's much more coordinated and longitudinal.
That sounds great, especially since Pennsylvania works through the system through the individual county providers. And so getting them to adopt it would be the hard part, but I think it would work well in a system like that.
Yeah, it's a good question. And the other part of that question that you're asking, Shannon, is, well, then how do you do that? And it does come down to some simple concepts of data governance and having a clear conversation of how do you create informed consents so that people coming to the programs know that this particular data is going to be seen by very specific providers and they know exactly who those are and they can opt in or opt out.
Wonderful. Thank you.
Any additional questions? I think, Stephen, you are still muted up.
Oh, I'm sorry. Can you hear me now?
I can.
Yeah, thank you for a great presentation. I appreciate it. We've had a couple conversations already about some of your work, and I wonder if you could spend a little bit more time talking about the tools use of the tools use for measuring well-being in the more abstract sense than specifically geared toward a recovery-focused population or a recovery-focused organization.
Yeah. So one of the interesting parts of the arc of recovery capital over the years is as it was centering out of folks in the recovery community, the framing of the questions were specifically to a recovery population. One of the things I learned in spending more time with folks from the Happiness Research Institute and the folks that do the World Happiness report every year is that with the Gallup Wellbeing Index and all these others, these questions already exist from a general well-being standpoint. We don't have to reinvent the wheel. Recovery or addiction just happens to be a condition that's external to the general well-being factor underneath. And so I can ask you, Stephen, or I can ask anybody, a question about your social connections, and I don't have to bring addiction or recovery into it. We can then make the judgment off of that relative to the particular condition somebody might be dealing with.
Right, or relative to where interventions might be supportive and helpful.
That's correct.
For that person.
Yeah.
Yeah.
We are going to get cut off in 2 minutes because I set a timer on this to make sure that we kept our time. Is there any other questions?
Just a quick thank you, David. I really appreciated this presentation as well as our ongoing work together. Thank you so much.
Thank you, Tim. I appreciate that. So I will share the recording with anybody who wants it. I'll put that back in an email to everybody. My contact information will be on the slide deck. I'll share that with you as well. And if there are any questions about recovery capital or ways that I can help you think about that at a global scale or even a micro level, please reach out. I'm happy to just think and brainstorm. So I'm grateful you all took the time and thankful that you joined. Have a great afternoon and a great rest of the week. Be well.
Thanks, David. You too.
Thank you, David.
Bye-bye.
David.